Okay, Amber is ordering, we looked at some other stand-up desks, so she's ordering, I think, 2 more. So try them out because they're different. They look a little bit more stable than the one that we bought. And then
It's up there.
Professor Lavatois brought the worker, is it right now?
It's already up there. Big roll of it up there. Just, is it?
Yeah.
Yeah,
just
so
roll
we
that
thought we
out.
could just roll it down.
I was
so-
gonna cut it and make y'all like placemats, and Amber said, so I'll leave it at that. Yeah, she said, just roll it out on the back there, so.
So you all try them out, and if you like them, we'll get enough for the back row, and we'll start there for the next class. Okay, so then we're going to start with this scenario. So we're going to talk about amoxicillin clavulanic acid. So amoxicillin is in what class? It's a penicillin. Okay, what's the clavulanic acid? Why is it there? If we took it away, does it fight the bug? No. So why do we put it?
Increases efficacy.
So it does what?
Decreases the virulence.
So it decreases the ability of that organism to metabolize or get rid of or inactivate the antibiotic. Okay? So it extends the effectiveness of the drug. Now, this is important to pay attention to. We'll see it's going to be different with different antibiotics. It's the amoxicillin portion that is the strength. Okay? So when you're dosing it, you don't worry about the clavulanic acid. It's always going to show up as the dose of the amoxicillin followed by the amount of clavulanic acid. Okay? They're usually in a ratio, but it doesn't always hold true. Okay? So the dose and frequency, pay attention to me instead of calculating. Just pay attention to what I'm saying because I boiled it down to the essentials. Then I'll give you plenty of time to calculate. The dose and frequency are product specific, so you cannot interchange them or substitute one for the other across the board. So it's important that whatever you order exactly what you want. Okay, because pharmacists can't go in there and substitute. Sometimes they can, but in this case they cannot. These are the 2 doses you need to remember. So there's high dose, which is the 90 milligrams per kilo per day, and there is the standard, the 45 milligrams per kilo per day. It depends on what you're treating. So otitis is high dose. Community-acquired pneumonias, those are the 2 common ones you're going to find it in, high dose. The standard dose, UTIs, that's an example, okay? So I would learn that 90 milligrams per kilo per day. Okay, so here is your scenario. So you have a 6-month-old. They weigh 17.5 pounds. They're being prescribed the Augmentin for acute otitis media. It lists there all the available. So it's important that you, when you're looking at those, what are you first going to think of? What's the first criteria by which you will rule in or rule out dosage forms? Age of the babe, of the child, okay? So some of those come right off, right? Can't use a tablet, can't use a chew tablet, right? Usually don't have any teeth by then. So it's going to be a powder for suspension. And what did we say in terms of when we're looking for a liquid, what's the first thing we try to look for? Amount. Okay, so how much are we going to, any of these are appropriate, it's the amount that we're going to have to give when we're dealing with a child. And then it's the recommended dose there is listed. So go ahead and calculate that dosage for that child. Yes. You can work together if you want, or you can work separate. How many days would you treat an otitis? 10, 7? Anybody else? How long would you treat it? 10 days, so figure out the amount. How many don't have it? Everybody got it? Okay, we'll walk through it, just to remind you how to do that. When you look at these, you see all these different prescriptions for powders. These are powders that are reconstituted by the pharmacist and given to the patient. They will have, you'll see 75 mils, 100 mils. Do not worry about that. The pharmacist will figure out how many, what container to use. You need to put on there how many mils you want for the course. The reason for that is it's not that pharmacists can't figure it out, it's another check. If you write a volume that doesn't make sense based on what you have done, I'm going to be calling you and saying, you've written this, it only should take this amount, but you've doubled the dose. Well, sometimes I'll go, well, there's another kid at home and I want you to put them on that. I mean, there's all kinds of reasons. Sometimes it's error. So the pharmacist will figure out the container. You just need to figure out how much will cover the prescription time. Okay? All right. So let's do this. So you converted the kid from pounds to kilos, right? Everybody get 8? Okay. So 8 kilos times 90 milligrams per kilo per day. So we note that that's a daily dose, is 720 milligrams per day. Everybody got that? Okay. So then, how do you figure out how many mils the dose is? Well, then that's where you have to pick your concentration of your liquid. Okay. I picked 600 because it's the most concentrated and I get the smallest volume. So everybody feel comfortable with that setup? Look familiar? So if there's 600 milligrams in 5 mils, then there's 720 in X mils. So you do the math and you come up with 6 mils. Was that for a day or a dose? That's for a day. So then you're using the 600 milligram per 5 ml. It's 360 or 3 mils PO BID. So that's how you would write that. And how many mils did you need for the entire prescription? 60. Everybody follow that. Is there anything you'd like to say about Promethazine?
Kids hate it, parents hate it, but sometimes you gotta use it. So just talk your parents into it. This is one where I really recommend the chocolate chaser because it's so bitter. And I just do, rather than on a spoon like your slide said, I have a second oral syringe full of the chocolate syrup, you know.
Yeah, that's,
medicine,
yeah.
those are the thing. Because spoons get, you know, they're throwing a fit and it gets knocked out of your hand or whatever. It causes diarrhea. I go ahead and warn the parents to start their kid on a probiotic and just put them on a probiotic. It might not help prevent the diarrhea, but the parents will feel like they've done something. And remind them if they do get diarrhea, it's going to stop it from getting in the medicine.
So what probiotic do you recommend for kids?
Fluorostor for kids.
Fluorostor?
Baby Gaia, Fluorostor for kids, any of those.
Okay.
There's a whole slew.
Okay. All right. The next two are the cephalosporins. I put down Keflex and Cefdur on your handout. These are probably the two most common. Keflex is a first generation. It's really good at soft tissue, mild infections. It's well tolerated, not many side effects. The only drawback is it's 4 times a day, 3 to 4 times a day. So that's the big drawback using Keflex. It's very cheap also. The other one is Cefdinir. This is Omnicef. It's a 3rd generation. and it's not very many of the third generations come in an oral form. So this is a kind of a go-to. Otitis, bacterial skin structures, more severe or more depth. Pneumonia can be used. Children with penicillin non-type 1 allergies. What's a non-type 1 allergy? Not anaphylaxis, so they may have had a rash. Could they have hives, if that was it? Possible. So you're looking to rule out anaphylaxis, a serious versus a non-serious. Okay, and why do we worry about it with a cephalosporin? Because there's a cross-reactivity, about 10%, still low. That's why they feel comfortable now using it with the non-type 1s. Comes in both of them come in a lot of different strengths, lots of suspensions, strengths are there. The Ceftonir also comes as a capsule, so does the Caflex. What is the one thing you've got to warn parents about if they take Omnicef? What's the big, it's a side effect, but it's not harmful, but it is, turns what red? Stools. Warn them, because it can be impressive. Okay, so anything you want to say about the cephalosporins? Okay, now the sulfonamide. So sulfamethoxazole trimethoprim is one of your big go-tos. In fact, it's been such a big go-to now, the resistance levels are going up. And I don't know in our area what it is. Do you have any sense of resistance in Oklahoma City area?
Not where PEDS is concerned,
Okay.
more so with adult medicine.
Okay. So here's the things to look at and keep in mind. Sulfamethoxazole trimethoprim, you dose it off the trimethoprim. Okay? So the milligrams per kilo are on trimethoprim dose. In all the combinations, it's always a 5-to-1 ratio, standardized. Okay. General dosing recommendation you need to know because you will commonly use this is 6 to 12 milligrams of trimethoprim per kilo per day. This you do note at, here you go Andrew, here's one of the ones you need to know. The max single dose is 160 milligrams per dose. So write yourself a note that you need to know that. Common, otitis, UTIs, prophylaxis, pneumonias, covers a lot of good bugs. A lot of bugs that are common to kids. So here's our scenario. We've got a 3-year-old that's 14 kilos. Well, I gave that one to you. So the notes there is you have a sulfamethoxazole 200 to trimethoprim 40 milligrams per 5 mLs. Determine a dose for 3 days. So you're going to determine the dose and then what do they need for the 3 days. Yeah.
The 8,
Use 8.
it's 8 per kilogram, right?
Yes.
Okay.
Oh, I was gonna say that.
In the box, it just says 8 milligrams TMP per day.
That's the recommended dose.
Yeah, the 8 milligrams per kilo per day. Sorry.
Oh, I see what you did. Okay, so 14.8, yeah.
Anybody not got it? Okay, let's look at it. Okay, so your 14 kilos per 8 gives you 112 trimethoprim per day. Everybody get that? Okay. So you divide the dose to give you your every 12 hour, and there's your 56 milligrams per dose. Everybody on board still? Okay. Then you're going to do your calculation that should give you 7 mLs, right? Okay. So the 6 doses required, so it's 6 times 7 is 42 mils for a 3-day treatment. Everybody get that? Questions about that? Anything you want to say about
No,
the sulfonamide?
you know, and Bactrim doesn't seem to taste too bad. Most kids will take it pretty well, even though, I mean, the max, I mean, you get never get more than 20 cc's a day, but, you know, it still is a chunk, but it seems to go down a lot.
They still use it for prophylaxis for otitis?
You know, yes, if you've got a kid that is, the EMT guys will say, if you've got a kid that's having these recurrent otitises, once you finally get it cleared, put them on the Bactrim just once a day. And so instead of the recommended 8 a day, you just do 4. Or you just figure out what would they take if you were doing a prescription for something and then just put it in half, just give them that half of that once a day. Does that make sense? Okay. And that, yeah, that works, and you keep them on that until they can get into the EMT.
One thing we were talking about while y'all were working is that range with sulfonamides is pretty wide. So the one that tells you is there's a wide margin of safety, but usually I will calculate that kind of in the middle. Then you can go up or down that, and that makes it a little bit more reasonable dosing wise or measuring wise, okay? But if they're really ill, you're gonna go to that higher end. Okay, let's go over to the macrolids. I didn't put erythromycin on here because it's so difficult to use, and you've got some good alternatives now with erythromycin. So these are upper and lower respiratory. So these are a fairly wide spectrum, just like you see with trimethoprim, sulfamethoxazole, community-acquired pneumonias, otitis, skin structures. So very, very versatile. You have suspensions, tablets, and it's 15 milligrams per kilo per day divided every 12 hours. Single max dose is 500. Most kids won't come close that are the younger ones. Zithromycin is also in that category. Were you telling me you don't use it in kids?
So they're never for an ear.
Never for an ear.
Never for an
Okay.
ear, but I use them, yeah, I use them.
Okay, so oral suspension tablets. So just kind of a reminder there. You'll probably see it show up in the prescriptions. Clindamycin, Cleocin. So this one, again, respiratory tract infections are good. Skin and soft tissue. Genital infections usually are responsive. So here there's 2 different doses. If you look for mild to moderate, it's the 10 to 25 milligrams per kilo per day, giving it as TID. Here you need to know max doses, so start out there, so 1,800 milligrams per day. The dosing for that more severe is when you have an MRSA cellulitis. So that one's an important one to know. So it's 40 milligrams per kilo per day, given every 6 to 8 hours. But look at there, you have a maximum dose limit, so it's 450 for a dose. Okay. The other one for the milder infections, it's per day. It comes in a liquid. I don't think the liquid tastes very good. It's like dirty socks. It's really disgusting. Capsules, you've got 75, 150, 300. So here's this scenario, the next one. Is you have a 10-year-old male, 10-year-old male, oh, this thing, sorry. 10-year-old male, 105.6 pounds. He's got a suspected MRSA cellulitis. You're going to put him on clindamycin, calculate the dose and the amount needed for 7 days.
Can you determine like 6 or 8 hours? Because that's, I for a kid, 1 extra dose a day is a lot.
Calculate what they need, and then I think what it's gonna guide you is that max dose. Yeah.
You're right, you do. Would be that, right, it would be that.
That's why it's in there. Everybody got it? Or at least as much as you can. It's meant to have ringers, because you're gonna bump up against these in practice. Okay, so you got your conversion to kilos correct? That's the first place to start. Okay, so you got 48 kilos. Okay, so 48 times 40, because you've got a severe infection, gives you 1,920 milligrams per day, right? So when you divide it up, then you get 480 every 6 hours, right? Okay, but your maximum dose was what?
450.
And that's what you go with. What is the, clindamycin is not a common antibiotic as first line. It's going to be when you got more virulent bugs, or when you've got somebody who can't use the standard, okay? And what do we worry about? What's the big side effect with clindamycin? C. diff, okay? So in a young kid, it can kill them. So we need to be we got to be real respectful of clindamycin. So you've got a max dose to worry about. Okay. So then you're going to give them 450 every 6 hours for 7 days. So how are you going to do that? Is there a 450 dosage form?
Do 3 of the 150s?
So how many of you used a combination of 300 and 150s? Okay, how many of you used 150s? Okay, they're not wrong, but I'll tell you, I would always, my perspective, I would go with the 150s. Whenever you introduce two different doses, you have the liable for error. So while it makes sense to you, it just is liable to get mixed up. So using the 150s, it would be 12 per day. For 7 days, you dispense 84.
Who did
What did you
liquid?
do?
I did liquid.
You're
I
brave.
started
Okay.
to, but I was like, no, it's too
It's never
much.
been my favorite.
I quit when I
30
got
cc's
there.
POQID times 7 days, so they're gonna get to take home a quart jug of.
Okay, so several different things in here to point out. One is that max dose, so that's what we go with. The other is that how do you, when you don't have a standard dosage form to meet it, how do you make it? Questions about that? Deciding at 6 or 8 hours, you can do 8 and get enough of the drug in. You'd be limited to what, 1350? Okay, let's see. All right, let's go back to page 10. So doxycycline, what kind of drug, what categories it fit in? It's a tetracycline. So here, we're looking at community-acquired cellulitis, soft tissue infection. They're really good against that. Usually they're not the first line, but they are very useful drugs. They can be used when others can't, or sometimes maybe they are preferred just because of some of the attributes. So children over 8 and over. Why are we not going to use it in younger kids?
Teeth.
Teeth, okay, and anything that's bone related. Of course, we don't worry about, I guess, what their bone color looks like, but the deposition of that gray color and discoloration. Okay, so 2 to 4 milligrams per kilo every 12 to 24 hours. I would say most people just dose it off of 50 to 100 to 200 a day. Use it once a day. Okay, the fluoroquinolones. What's special about them in kids? Pardon?
Like cartilage, soft tissue development?
So you can get, remember there were all those, we looked at, it's the tearing of cartilage, so especially Achilles, so weakened cartilage, so it's usually not recommended in children. When they've gone back and looked at large series, that it's more unusual. But the other thing with the fluoroquinolones is they are really good antibiotics. And they're usually well tolerated, so people have gone more and more to them, and now our resistance patterns are too high. So we're going to ruin those drugs if we don't stay away from them and use them only when needed. So you're usually not going to use them in kids unless they are really ill, and you can't use the other medications. So complicated UTIs, if you'll remember, we're not going to use the fluoroquinolones in UTIs anymore unless we have to, because they're the resistance levels. Pyelonephritis, they're really good there. Community acquired pneumonia, also good. And listed there, 10 milligrams per kilo per day, you've got a max dose, and then for serious, you've got about a doubling of that with a max dose of 750. Questions about those? Okay, let's go to page 11. NiStat, one that you'll use pretty common. Thrush in kids, asthma kids, steroid users, their thrush will show up. So we use antifungals. We usually do use NiStat in uncomplicated. It does the trick. It's well tolerated in most kids. You're going to use the azole derivatives when you have more complicated or immunosuppressed. So they are not the common. You'll use them more in adults, not as common in kids unless you run into the other immunosuppressants. You're responsible for 2 of those dosage regimens, and they're highlighted there. So in immunocompetent infants, NiStat and suspension, a little white bottle in amber glass. For neonates, it's 50,000 units to each cheek, so you've got a dropper that's calibrated that you can squirt it into each side of their mouth. For infants that are 30 days or older, 100,000 units to each cheek 4 times a day for 7 to 14 days. So it's a pain because it's frequent, it's often, and it's drawn out. Children with mild oral candidiasis, you're looking at 400 to 600,000 units of a swish and swallow. So if the kid can cooperate, you want them to kind of move it around in their mouth, coat the mouth, and then they can swallow it. The lozenges are usually for older kids, maybe adults will use those as well. What would you like to say?
What are you gonna think of when you're treating a 6-month-old infant with thrush? What's one thing you wanna know? No,
The nipple of the mouth as well.
yeah, are they breastfeeding, are they bottle feeding? If they're bottle feeding, they're not cleaning their nipples properly. Otherwise, a 6-month-old is not likely to have thrush. So then you need to talk about how to clean the bottle nipples. If they're breastfeeding, what are you gonna tell the mom to do?
Get treated as well?
Yeah, every time she does the kid, she gets to be Lady Godiva and put the suspension on her nipple and then let it air dry. Yeah, so 4 times a day. Yep. Try doing that while you're pumping it. But yeah, you gotta treat the nipples of the mother if they're breastfeeding or teach them how to appropriately, or just pitch all their bottle nipples and buy fresh. You know, once the kid's been on the suspension for a couple of days, and still talk to them about how to clear them. And I generally just 1 cc each cheek. Is that how it comes?
Oh, I don't even remember this.
I know, that's the
Didn't
thing.
write it down.
Yeah, so it's 1 cc on the little ones and 2 cc's each cheek.
The,
On the infants.
I don't know, it's a calibrated dropper, so I don't know, I just go by what's on the dropper. So the 1 cc, I don't know.
I've never
You got me
been,
there.
I've never been called back on a 1 cc each cheek. Yes.
For the children that can swish it around, do they have to swallow it for it to be effective, or can they spit it out and it still work?
Well, you gotta think about this. When you swallow anything, where does it go? Down your
Their stomach.
esophagus. So if they have thrush in their mouth, odds
Okay.
are there's
It'll go
probably
down,
thrush in
yeah.
their esophagus. So
Okay.
I would not encourage them to spit it.
Especially kids that are on steroids, they often will have it on down their mouth or their larynx. So having them swallow, it's a good idea.
Bricky's has it as 1 mil for preemies or low birth weight neonates QID, and then infants is 2 mils POQID, and children is 4 to 6 mils POQID.
And when we say
I
each,
think it's 100,000 units
Per mil.
Because it's like
I
a
think
brown
it is.
bottle.
I think it is. but the thing is, and when you do each cheek, you open their mouth and pull the baby's cheek out and then just really empty the dropper full in there. After they eat, not before, and then just let that stay in there because the baby will naturally, move their tongue around and it'll coat their mouth.
How do we decrease that in an asthma, a kid on an inhaled or corticosteroid? What do we tell them to do? Spacer and rinse and spit. Okay, it won't get rid of all thrush, but it'll certainly help. Okay. Pain management. So you've seen this before, we've talked about it multiple times. The use of Tylenol or ibuprofen, they're equally effective. Mechanisms are a little bit differently, doses are different, age groups are different. So for Tylenol, the dose is 10 to 15 milligrams per kilo every 4 to 6 hours. So there's a dose, a recommendation per dose, not per day. And then you've got the max of 5 doses in 24 hours. The big thing is choosing the appropriate concentration. They have now narrowed that down, so there aren't a plethora of ones to choose from. So using that 160 per 5 is usually the good one to do. The suspension, always talk to your parents about shaking it up, because what happens if they let a suspension sit, what happens? They overdose at the bottom, they underdose at the top. The ibuprofen is 4 to 10 milligrams per kilo every 6 to 8 hours. You have a max that's in dose is 40 milligrams per kilo per day. Don't use in kids under 6 months. So you're going to use the Tylenol if you have to before that age group. There you've got 2 different suspensions. So you have one that's more dilute, use that in your young kids, and for your older kids until they can take a tablet or a capsule. You've got the concentrated one of 40 per mil. You don't want them to mix that up.
That's why they do away with the infant
Yeah, that's why they did away with the infant Tylenol.
They have to, if they, a lot of times the grandparents will still have an old bottle of Tylenol, but by now it's expired, so tell them to check
Tell them to
it.
toss it,
Tell
yeah.
them to check the expiration date.
Okay, so here's your Tylenol, kids, 4-month-old, 17.6 pounds. There's your dose, max dose, suspension, calculated dose for them. Everybody got it? Dylan, when you find that, let me know. Okay, so you converted to 8 kilos, right? So you've got an 80 milligrams at the lower end, right? That makes it easy. So your suspension is 160 per 5, so it's 2.5 mils every 4 to 6 hours. Anybody use the 15? So the 15 was what? 3.75. Okay, so there's no way you can't actually draw that up. So that's where you're gonna have to round it up to 4, or you're already at the top, though, that was your 15, right? So going somewhere like in the 12. For mild pain, this is gonna do it. Did you find it?
I think so. You're looking just for the dosing?
So they used to, on the Tylenol, put the age-based. I wanted to know, do they still use age-based? Okay, so at home, the parents are going to be looking at an age-based dosing. You can go over with them and give them a recommendation of a weight-based dosing.
Or at every well child check, they get the dosing chart with the arrow drawn for their appropriate weight at that well child.
Yeah, McNeil puts out a dosing chart that you can hand out to parents.
And they give you for free. They will
And that you
provide
can
with-
order.
Yeah, and at every well child check with the parents that I felt like needed it, or just seemed unsure, I would just give them an extra dosing chart with an arrow drawn to the appropriate, the age, or the weight, the
Yeah.
weight.
And if they have more than one kid, make sure that they know the difference, okay? So this is an important one, because they got trouble, but the age, does it go 2 to 5 and 6 to 12, or 6 to 11?
Yeah.
2 to 11? What do they say?
It's the same dose there, 160.5 mil, but the,
But did they give an age?
on the back here, yeah, there's, no, it's actually weight-based.
I remember.
Okay, so they can order it, that's what I was, okay, that's what I'm telling you, I would go over with my parents, make sure they can calculate that dose, and then give them a backup also in terms of the handout. You can go onto the website and you can order them as a practitioner. I think they come in rip-off pads
They do.
like 100 or something.
No, it used to be age-based.
It
Because I
did.
remember when my kids were little, 2 to 3 years old.
Right.
Yeah.
That's why I wanted him to check, because
They
that's,
left it on there, it's split into 3 columns, they have weight-based, age-based, and then they'll tell you the dose.
okay,
So
okay, so they do both as a check. Okay, that's good. Okay, here's ibuprofen. So a 5-year-old, 44 pounds, calculate the regimen for ibuprofen. The suspension used the 40 milligrams per mil.
Is the 40 milligrams per mil,
Yes, exactly.
and was that concentrated over the counter?
Yeah,
I think so.
Yeah, you buy ibuprofen, infant ibuprofen.
So it's not 100 for
That's
5?
not children's.
Okay.
There's a difference.
Now you can get a concentrated infant.
Because infants is more concentrated.
They make a concentrated.
I did
dye-free,
say-
so they spit it back in your face.
A lot of them are diet-free.
Yes. You could. That's a orange flavor.
Second.
You can only do the children for the high dose.
I don't know, you'd have to calculate it.
The low dose was 80 milligrams per dose.
For this kid?
We're talking ibuprofen.
Is that what you
Like
said?
77.
Oh, you just picked
6.
one. I just did the
You
low
just
dose.
want to make sure you don't. You just divided it first, you do not need to divide it.
Yeah.
Just start with 80. You're 80 for X.
Yeah. These aren't pretty.
Everybody got it?
Yeah.
For, yeah.
Okay, did you get 20 kilos? Okay, so if you do it by the calculations, your range is 80 to 200, so you can choose somewhere in between there. I'd say depending on discomfort of the kid. But with the 200, you're getting close to the max dose, right? So max dose is 800, so if you dose it 4 times a day, you're right there. So if you use the suspension, it's 2 mils or 5 mils every 6 to 8 hours, and some of you suggested using the chew tap, which you could, but I'm asking you to calculate. So, questions about that? Okay, anything else about the, you want to say about those?
You know, I spend a lot of time educating parents on how to dose ibuprofen. Seeing the differences between, and teaching them the generics. And
Yes, so you hear that?
Yes, so you don't have to spend all the money on the brand name.
Yeah. So especially if you're a first-time parent,
Oh, yeah.
or if other suspicions are raised with multiple kids. Okay, all right, let's move on to asthma then. A few things in asthma. This was one that the second year said to review, that's why I'm bringing it back in there. So we've got nebulized, the short-acting, we've got nebulized and meter dose inhalers that we're going to look at. I'm not going to ask you this first section, just I want you to remember about, you've got acute dosing and you've got chronic dosing, so they're different. So for the acute setting, you're going to give dose every 20 minutes for the first hour and then put them on a more a regular dosing, usually for a few days. If kids have an acute asthma exacerbation, you're usually going to use that short-acting bronchodilator on a regular schedule for a few days, or at least that's what I did, I don't know.
Definitely.
And if they're post-viral syndrome, I may even use it longer until that coughing and that airway settles down a little bit and the steroids have had some effect.
Do you always taper your
No, I usually just let it because that kind of gave me an idea of what was going on under the, in the airway. Do you use a taper?
I do. I would tell them to do a neb treatment 4 times a day for the first 2 days, and then go to 3 times a day for a couple of days. And then just taper it down. That gives them about a week in neb treatments.
Mm-hmm. Yeah, I don't think that's bad. I would let them kind of self-taper, and then they tend to start wearing off anyway. Kids getting up and running around and not as active, or is more active, and so that kind of also tells you, can they tolerate the activity. Okay, so nebulization products there at the bottom gives you, I put in this YouTube, if you are unfamiliar with nebulizers or how you prepare it, and put a dose in the medicine well of a nebulizer. This is a nice little short YouTube that you could watch. So there are 2 different ways that the solutions come. There's 4 different dosing strengths. They're either going to come, most of the time what you're going to be doing is prescribing, whoops, let's see, I can't do that one. Okay. Is you're going to be looking at, why does that not show up? Oh, it's probably because of the presentation. Okay. Whoops. So this, why is that not?
You need your finger on the stove.
It's so short, I don't know what to do. The mouse won't show up.
Yeah.
Is it showing up for you, but it won't show up up
That's
there?
a new thing since they got the
Since they got the new
computer.
system, you used to could use the mouse.
Okay, so these are what we call unit dose. So each dose is in a unit that the patient can access and use. This would be a liquid and it's got a dropper. I would say when you're using it, get your dose as close to one of the unit doses you can. They're more expensive, but they don't have to add anything. They can take that individual dose, looks like this, it's plastic, has a twist top, and it's 3 mils, and they can squirt it all into the medicine well, and it's ready to go. If you use this, which I did when Kara was a baby, I had to use this, but I have to add normal saline to it. I have to dilute it down. So this one can be used. It's a higher strength, has a little bit more flexibility, but these are probably what you want to go after, are those. They're more expensive. The insurance companies are going to come after you because nebulizers are expensive and those are expensive. So they're usually going to want more justification because most kids, over the 12 months, you can use a face mask and a meter dose inhaler. But if you have to use them, that's what you're going to want to go after. So in terms of dosing, there's multiple dosing schedules. And on the next page, even though people use them in kids under 2, that there's just very limited data to guide dosing. You have that 0.6. If you look on the page before, you've got that really low dose, that 0.63 milligrams per 3 mLs that you could use in a very young child. But most of the time, if you're looking at 10 to 15 kilos, you're going to use that 1.25. And if you're over 15 kilos, then 2.5. Most adults are going to be 2.5 to 5 milligrams. Now, when I'm talking about this, I'm talking about using this instead of a meter dose inhaler. So do we chronically, maintenance-wise, going to use this all the time? No. So we're going to use it just like we would an inhaler and use it PRN. And we're going to use that as a guide to tell us what? What do we use that usage to help us know about?
How severe their asthma?
How severe the airway, state of the airway. The more inflamed it is, the more often they'll be symptomatic and they'll have to use that bronchodilator. So it tells you whether the steroid's working, do they need to go on a steroid, an inhaled corticosteroid. So it's really important that they have access. What's the downside, what's the good side of a nebulizer? What would you think? Okay, let me ask, let's go through the next and I'll come back and ask you about that. Usually when kids get about, I've done it with 12-month-olds and above, but usually about 18-month-olds you can start to use an inhaler and a spacer device. So if you look on page 16, there are different sizes of spacers. The lowest one is the small, and that's for infants, 9 to 12 months. You can use those. Medium is more for kids, and the large are more for adolescents and then or adults. Okay. They all come with masks. You're always going to use the orange and the yellow with a mask. And then when you get up to the large, they do make a mask with it, but usually by that time you can just use the mouthpiece and not use the mask. So the dose on the albuterol, you must know it's the same across ages. You also need to know the strength. The strength is standardized for albuterol inhalers. It's 90 micrograms per puff. So for everyone, it is 2 puffs every 4 to 6 hours is needed. So kids, you need a spacer at least until they're 5, 6, 7, 8 years old, because you've got to have the ability to coordinate your brain and your muscles and your mouth all together. So that's why a spacer makes sense. Spacers also are, if someone has perfect technique, a spacer does nothing to enhance it. So spacers usually help when you have poor technique. And the majority of patients have poor technique. I almost always give a spacer. Some patients will use it, some well, they won't. But I like them. I think they work better. I feel like I'm more reliable that the drug's going to get in there. So now looking at that and looking at a nebulizer, what's the advantage of a nebulizer? It's higher. Why is it higher strength? That's
It doesn't all get to the patient.
Right. So the dose of what you get with an inhaler and what you get in a nebulizer are about the same, but you lose a lot when you aerosolize it. Okay, what's another advantage to a nebulizer?
You don't need a perfect technique.
You don't need a perfect technique. It's passive. You just sit there and breathe in and out. Okay. So what's the disadvantage of a nebulizer?
Takes longer.
Takes longer, about 15 or 20 minutes. What's the other thing?
More medicine.
Okay, technique is nothing with the nebulizer, but it's not portable. They're smaller now. You could take them with you. They're not practical to go. So if you are going to be out and about, you can't treat a child with a nebulizer out and out. Okay. So that's the biggest thing. You want to move people towards the spacer and the inhaler as quickly as you can. Equally effective, we talked about that.
Sometimes in my practice, a lot of times when I'm dealing with viral stuff anyway, there's just the humidity that comes with the nebulizer helps. And a lot of times if I'm going to give a parent a nebulizer, I'm going to get them a nebulizer. Dr. Johnson's office has them available for loan, for short
Oh,
term.
yeah?
So,
Oh, that's
yeah, she loans them out. And then you just write them for the medication. And I would never ask a parent to mix that, to calculate that with a little dropper. So what we do is when we set them up and we're giving them their neb treatment, their first ever neb treatment, me and the nurse are in there together, we're showing them how to do it, and I take it all apart and I say, okay, I'm going to put the medicine in, but when you do yours is going to come in this vial, just like this saline is, and you're just going to pop open a vial and put it in there, because then you're showing them how to do that and mix it. And
Yeah, that's good, yes. That would be very preferable. Let's see. Did it ever come up in discussions with other practitioners about using levoalbuterol instead of albuterol? Xopenex. You will see it used a lot in the ER. It's not generic, so it has people that go out there and push it. It is the L isomer, it's the R isomer of, albuterol. So albuterol is a racemic. It is the R and the S isomer, okay? The S isomer, what you'll hear come out of the reps is they will tell you that the S isomer has bronchoconstricting activity, and that's true, a very low amount. And the R isomer is where we get all of our activity. So the levalbuterol is just that isomer. But in head-to-head, there's no difference. They are equally effective, and that levalbuterol is much more expensive. So I'm telling you, I'd always go with albuterol, but you will probably see the other come up, and people may prefer it.
They think it makes their kids less hyper.
Oh, really?
Less side effects.
Patricia was the one who said that.
Mhm.
She said, hey, parents like request it
They
specifically, like
request,
will you
even though
pay
their
for it?
insurance won't pay for
The
it.
dose, the cost is extremely different. Okay, any questions about those? Okay, so I want you to know fluticasone and I want you to know budesonide dosing. I'm going to show you the easy way to remember it. This is how I do it. So with the inhaled corticosteroids, there's lots of them. I like fluticasone. At the lower end, it's comparable to the least expensive. All of these are expensive. They all start at about $150 an inhaler and go up from there. So they're all expensive. Beclomethasone is probably the least expensive, but you also have to dose it at least 4 inhalations per dose. And it's the least potent. So I like fluticasone. It is also approved for all the way down to the lowest age. So it has approval across all age ranges, so I like it for that reason. It comes, let me go down through here. Remember, doses are divided into low, medium, and high in asthma, and which one you use is determined by the severity of the asthma. Okay, so most of the time you're going to start off with the low. If they have seasonal or intermittent asthma, then we usually just use a bronchodilator. But then when they're all those things that we talked about in terms of asthma, like what are the big things we look at when we're assessing our severity?
Nighttime awakening?
Nighttime symptoms,
Albuterol use.
how often they're using their albuterol,
How much?
how much it's interfering with daily activity,
ER visits.
ER, in particular, we're looking out of that ER, what did they get? Prescription for what? Steroids. Steroid, how many steroid bursts? Have they had to be hospitalized? What else?
FEV1.
FEV1, so, and we don't measure their FEV1, we use what?
Peak flow?
Peak
rate?
expiratory flow rate. They're very similar. Okay, so we look at all those things, and then we're going to then judge severity, and that will dictate. If they've got a mild, persistent asthma, they're going to use the low. If they have step 3 or 4, and they've got more moderate persistent, then they're going to go with that medium. I told you I like to start with the highest and back down. I feel like you get the best. Instead of having to keep going up and trying to find the dose that controls them, I like to start high and then back down. So here's the way I think is easiest to learn these. Don't